discussion. And well, I'll take the first opportunity and ask, Professor Bashar regarding, his what you call diabetes on fasting calculated risk, which he's carried on. Professor Bashar, you mentioned that, the patients who, want, or the pregnant patients, although they are pregnant and we encourage them not to fast, but they still fast. I think the main reason for that we don't have enough studies for pregnant patients who fasting, whether they have diabetes or they don't have diabetes. There are very few studies on this, and what is the outcome for the mother and for the baby. There are very few studies, and I believe that we need, more studies in this matter, so we can say whether it is really so highly, high risk for these pregnant patients or not. What do you say here?
Yeah, exactly true. Now, we had a small study on GDM on diet patients and also on metformin, and we showed clearly that patients with GDM on diet only, they get hypoglycemic before iftar. And it was very interesting that when we did the CGM study on these patients, they do not check their sugar at the right time. So when we compare, they do not check their sugar using the SMBG before iftar. So that was, relying on their records is really misleading. They give you readings that are okay, but they don't check in the right time before iftar and so. So even patients on metformin or on diet alone, they get hypoglycemic actually.
But regarding the babies, there was any risk on the babies during the fast for ladies who fasted Ramadan or not?
I'm not aware of long-term studies on that thing, but we know that GDM alone is associated with the long-term alone without diabetes, without Ramadan fasting, is associated with increased risk of premature babies or smaller for gestational age, and probably a few years later compensation large babies and big head circumferences. So yeah, there are no studies actually on Ramadan and follow-up on the babies, yes.
So Zanaria, what about Malaysia? Do you have any studies on pregnant ladies who fast Ramadan and the risk and the outcome? Any studies you have there in Malaysia?
Not recently. I think that's one area we will definitely have to look at.
Professor Muhammad Hassanein, you mentioned that the elderly people follow more. The advice not to fast if they are in a high-risk group. And that is true, but why? Do you think that because they are older, they are wiser, or they are more scared of getting complications, or, but here, one thing you said, it is the age and it is the duration of diabetes, but I believe it is the general health of the patient. Age does not matter as much as the general health of the patient, whether they are, in a good health or they have comorbidities.
You're absolutely right, Dr. Abdrazak, and that's why it's a point in this core process, and it's not the point as it was in the previous guidelines to say yes or no. No, it's only one of the points, whether it's age or duration of diabetes, that within the 14 risk categories will make you have a plan. So if I'm in my 70s and I'm quite healthy and I have no issues, then I will be able to fast. But on the other hand, if I'm even younger and have lots of health issues, then it will be important for me to take the advice of my healthcare professionals. And actually, as you mentioned, it is the patients themselves who decide on, I don't feel as good, I don't feel as healthier as I was in the past. And that's why the rate of fasting in the older age group was 70% versus 91% in the younger age group. And the same was for the duration of diabetes. And that's why I feel that the risk score by Dr. Suleiman was excellent in the general points. But obviously, to come to the details of which factor is identifying, we do not have any factor that is identifying in the risk score, because it's the amalgamation of the accumulative factors together, rather than one factor will make you say yes or no.
But I see, the risk factors by Dr. Suleiman, it showed that even in the high risk group, the majority, more than 70% of the patient fasted the whole 30 days of Ramadan, and the hypoglycemia rate was not that high. Dr. Suleiman, can you comment on that?
Yes, certainly. So the overall rate of fasting is quite high, higher, of course, in the low risk group, but still quite high in the high risk group and the intermediate risk group. And we looked at this further by looking at, I think this is similar to what was being presented before in some of the previous studies here. A lot of patients actually did have hypos and they still fasted. So we asked patients, how many days have you fasted? And they say either 30 or nearly 30. And have you had hypos? And they say yes. And they didn't break their fast. So I think this is also a point, as identified in other studies, I think a point for education. I think we need to stress these points about the cutoff points where they should really fast. And I think this is also, as Dr. Bashar mentioned, doing the risk score is an opportunity for education and telling patients, okay, your risk is high, you plan to fast, but please, if you plan to fast, if you reach this level of hypo, this level of hyper, please break your fast, and you have the exemption, you have the permission from a medical and from a religious point of view.
If I may to add point, Dr. Abdulrazak, it's just risk calculation. It doesn't say it will happen or not. It's like anything else. Smoking, for example, on the packet it says can cause cancer, can cause heart disease. There are a large number of people who smoke and they don't get it, but it's definitely a risk. So the score is guidance to people on the possibility of a risk, and it's not, doesn't mean that it's definitely going to lead to a problem.
Professor Jamal?
Yes, there is a question for Dr. Suleiman from one attendees. Thanks for the good presentation. Was the method of glucose testing, SMBG, CGM, or the number of tests every day in SMGB matched between the groups?
That's a very good point. In fact, we looked at in the multivariate analysis at whether the different groups of SMBG, whether they did it appropriately, whether they didn't do it at all. And it wasn't actually differentiating in the ability to fast the full 30 days or in the probability of hypoglycemia. We do have, among our 647 patients, we do have about 61 patients who have CGM records available, and we're planning to look at that. Because as Dr. Bashar mentioned, there might be a lot of hidden hypos which are not detected on routine SMBG, and this may appear on the CGM. But to answer the question about SMBG, it wasn't predictive of the risk of fasting.
Thank you, Professor Suleiman. Another question for Professor Bashar Effendi. I want to know regarding the risk, so that at what time I start to change the regime and when I restart after Ramadan to previous one.
I'm not sure I got the question correctly. Can you, say it again, please?
I want to know regarding the risk. So at what time I start to change the regime and when I restart after Ramadan to previous one?
Yeah, I mean, there are some data about this. You could, I mean, you should do a few weeks before Ramadan, and then you could, I mean, try 2 days of fast every week for a few weeks before that, and adjust the treatment and try fast and so on. So there are some, I mean, ways to do that. You might try it before Ramadan, adjust medications, and again, very important point we did not mention. I mean, you should have an access to your patients after you give them instructions and you agree with them if they want to fast or not, and you modify their treatments. You should have an access to them, I mean, through education or yourself to still monitor them and still modify their treatment further. I mean, throughout Ramadan, actually. Especially we have a hotline, for example, at Tawam Hospital, we have a hotline and our patients contact us throughout the day. I mean, especially in the first week, we get a lot of consultations and we still modify their treatment further.
Thank you, dear Bashar. I think we can close the session now. Many thanks for all the speakers, for all person who asked the panelists, and many thanks for my colleague, Professor Al-Madani. Now we close the session and we go to the next